Welcome to the Explainer. Today we're diving into deep vein thrombosis, or DVT. But look, we're definitely not just going to sit here and read textbook definitions. No way. We're jumping straight into a high-stakes clinical scenario that has literally tripped up countless medical professionals. Let's get right into it.
All right, picture this. It is 2 a.m., you're on the ward, and your pager goes off. You're called to evaluate a 62-year-old patient. She's on post-op day 3 after a laparoscopic hemicolectomy. And honestly, she was doing perfectly fine. But now, she's complaining of this mild, kind of dull tightness in her left calf. You go to examine her, and there's no obvious redness. But when you pull out the tape measure, her left calf is exactly 1.5 centimeters wider than the right. Okay. You calculate her well score, and it comes out to 1 point, which means moderate risk. You decide, hey, I'll order a D-dimer blood test, and bam, it comes back blaringly high. We're talking markedly elevated at 2,400. So what exactly is your next move here? Do you pull the trigger on immediate therapeutic anticoagulation? Do you order an urgent compression ultrasound? Or do you just send her straight for a CT pulmonary angiogram?
Well, here's the crazy part. Relying on the D-dimer in this exact moment is a massive trap. It leads straight into a cascade of errors, like totally over-investigating the patient or exposing them to unnecessary bleeding risks. The data actually points us to one very clear path. You need to order an urgent compression ultrasound. So the crucial point is that for this specific post-op patient, that D-dimer test you ordered, it is essentially useless. You see, tissue trauma and post-surgical inflammation make the D-dimer incredibly inaccurate. We are talking about near 100% false positive rates in this setting, and this is the exact trap that catches roughly 70% of junior doctors at 2 a.m. To really understand why this happens and, more importantly, how to avoid it, we need to look under the hood at how these clots actually form in the first place.
Let's dive into the biological engines driving DVT. It really all comes down to Virchow's triad. These 3 factors combine to create the absolute perfect storm for a blood clot. First up, you've got venous stasis. This is essentially a loss of normal, laminar blood flow, like when a patient is immobilized in a hospital bed for days on end. Second, endothelial injury. This means direct trauma or inflammation to the blood vessel itself, maybe from a surgical incision or an IV line. And third is hypercoagulability. This is a systemic shift in the body that just makes the blood way more prone to clotting, which can be triggered by things like active cancer, genetics, or even severe infections. Now, unlike those high-shear arterial white clots that are mostly made up of platelets, these 3 specific factors combine in our veins to form what we call low-shear red clots.
To really visualize this, try thinking of the venous system not just as a bunch of biological tubes, but as a river. We use this analogy called silent silt. So imagine a wide, slow-moving river with these natural wooden floodgates built in. Those are your one-way venous valves. Now, if the water is flowing fast, the riverbed stays completely clear, right? But if you have stasis, the water just slows to a total crawl. The riverbanks start to erode. That represents the endothelial injury. And heavy sediment begins to pile up right behind those closed wooden valve gates. Down inside those little avascular valve pockets, the oxygen levels drop. And this localized hypoxia is the spark. It triggers the coagulation cascade, weaving this incredibly sticky fibrin mesh that traps passing red blood cells into a fragile, muddy dam. And that mud dam, that is your thrombus. So you might be wondering, why does this matter? Let's bring this right back to clinical reality. Why does this exact microanatomy matter if you're, say, positioning a patient in the operating room at 2 a.m.? Let's say you suspect an acute iliofemoral DVT, which is a massive, highly dangerous clot up in the upper leg. Why on earth is it strictly contraindicated to aggressively massage or squeeze that patient's calf while you're examining them? It's because of that fragile mud dam we were just talking about. Those early venous thrombi are only very loosely anchored to the vein wall by super fragile fibrin strands. If you go in and mechanically squeeze the calf, you're exerting sudden hydraulic pressure, and that pressure can literally shear the entire head of the clot right off the valve sinus. In a split second, you could transform a localized leg clot into a massive, fatal saddle pulmonary embolus before the surgical team has even had a chance to scrub in. This is absolutely high-stakes medicine. And by the way, it is amazing what we can all learn from each other's split-second decisions in these high-pressure scenarios. So please drop your own clinical close calls or experiences with DVT management down in the comments below. We love to read them.
Let's move to and see how this builds into our actual diagnostic algorithm. The great thing is we don't have to guess in the dark. We use the gold standard well score. This system assigns points for specific risk factors. You get points for things like having active cancer, having recent major surgery, or having an entirely swollen leg.
But pay attention to this incredibly powerful negative weight at the bottom. If an alternative diagnosis, say a Baker's cyst or torn muscle, is more likely, you actually subtract 2 points. The math here is vital because this score dictates your exact next step. If that score comes out to 2 or higher, a DVT is considered likely, and in that case, you skip the blood work entirely and proceed directly to the gold standard test, which is the ultrasound. But what happens if the score is less than 2? That's where we need to contrast our 2 main diagnostic tools. First, the D-dimer. It has incredibly high sensitivity, which basically means it's fantastic for ruling out a DVT in low-risk patients. And here is a brilliant little clinical pearl for you. For patients over 50, use the age-adjusted formula. Just multiply their age by 10 to get their specific cutoff limit. This simple math trick vastly improves your accuracy without overdiagnosing people. But hey, remember our 2 a.m. post-op patient? Her D-dimer was totally useless because of all that surgical inflammation. For her, we have to rely on the gold standard, the compression ultrasound. It's the standard for one very simple reason. The definitive hallmark of a clot isn't just seeing a dark mass on a screen, it's the physical inability to compress the vein with the ultrasound probe. A normal, healthy vein collapses under pressure. A vein full of that silent silt we talked about, it pushes right back.
Okay, so once we actually confirm the clot is there, we follow the modern CHEST 2021 guidelines for treatment. This is broken down into 3 distinct phases. First is the initiation phase, where we aggressively tackle the acute clot for the first 21 days using high-dose blood thinners. Then we move into the treatment phase, which maintains standard dosing for a mandatory minimum of 3 months. Finally, there's the extended phase, which looks beyond that 3-month mark to focus on secondary prevention in high-risk patients. But listen, here is a critical concept you absolutely need to grasp. These anticoagulants do not dissolve the clot. They really don't. They simply halt the propagation of that sticky fibrin mesh. They hold the line so that your body's own internal cleanup crew, an amazing enzyme called plasmin, can come in and slowly break down the matrix over weeks and months.
Now, what's really interesting about this slide is the pharmacology of how we actually achieve this. We have direct oral anticoagulants, or DOACs, like apixaban, which is often our first-line choice simply because of its low bleeding profile. Then there's rivaroxaban. This one has a fascinating little quirk. At higher doses, it absolutely must be taken with meals for proper absorption. But then we have warfarin. And guys, this is where you can cause some serious harm if you aren't super careful. Warfarin initially inhibits your body's natural anti-clotting proteins much faster than it inhibits the pro-clotting factors. So if you start a patient on warfarin without a mandatory 5-day overlap of a fast-acting heparin bridge, you actually create a temporary prothrombotic state. The result of that? A catastrophic complication known as severe skin necrosis. Absolutely brutal. Now for the most massive, severe clots, like when an entire leg's blood flow is literally choked off, we have some incredible, cutting-edge, advanced interventions. Instead of just sitting around waiting for the body's plasmin to do the work, interventional radiologists can now step in with percutaneous mechanical thrombectomy. They thread a specialized catheter right into the vein and literally core out or vacuum aspirate the thrombus in a single session. This restores venous patency instantly, without the massive bleeding risks you'd normally get from systemic clot-busting drugs. We can also place venous stents to prop open anatomically compressed veins, like in May-Thurner syndrome. And if we're looking to the future, keep your eyes on factor XI inhibitors. Early trials are suggesting they might literally be the holy grail of anticoagulation, drastically lowering clot rates with near-zero major bleeding risks. It is super exciting stuff. As we wrap up this explainer, I want to leave you with a really profound piece of senior attending wisdom. Treat the patient, not the cath echo. Medicine is an art of treating humans, not just treating imaging results on a screen. If you find a small, isolated clot strictly in the calf veins of an asymptomatic, low-risk patient, they often don't need dangerous, aggressive blood thinners right away. Sometimes the absolute best medicine is simply serial ultrasound monitoring over 2 weeks to ensure it isn't growing. This spares them from totally unnecessary bleeding risks. So I'll leave you with this provocative thought to ponder. In an era of hypersensitive testing and incredible high-resolution imaging, is the absolute hardest clinical skill left to master knowing exactly when not to intervene? Think about it. Thanks for joining me for this explainer, and I'll catch you in the next one.